So let's move to the first quiz, which we had broadcasted on various groups and social media platform through Indian Radiologist. So this was the first case which we had shown, where you can see a small intramedullary lesion which is hypo-intense on T2 weighted images with lot of perilesional edema in the spinal cord, and on post contrast you can see that it is enhancing as a small nodule. Apart from this lesion in the spinal cord, this patient also had few similar lesions, enhancing lesions in the brain parenchyma, which were solid as this eccentric nodule, and most of the part of the lesion was cystic. So this is a case of hemangioblastoma, one of the differentials for intramedullary spinal cord tumors. So cyst with intensely enhancing mural nodule. There will be prominent subcutaneous flow voids reflecting hypervascularity, marked post-contrast enhancement, and common locations is one of them is cerebellar hemispheres and also can be seen in the spinal cord. Association is with the von Hippel-Lindau syndrome. Next quiz case was this, where you could see a lot of multiple vertebral body showing areas of altered signal intensity and also wedging. So what is this? This is Kummell's disease. And what is Kummell's? It is intravertebral vacuum or fluid cleft sign, delayed post-traumatic vertebral body collapse, where you see T2 or stir hyperintensity surrounding the cleft and dynamic instability on flexion extension if it is performed. So this is like avascular necrosis of the vertebral body setting in, which needs to be informed in your report to the treating surgeon. Third case is this on your screen, where you could see a heterogeneous signal intensity midline tumor, which is showing areas of, again, heterogeneous enhancement and non-enhancing necrotic areas as well. The solid component on ASL, which is non-contrast perfusion, is hyperperfused. This is just a 23-year-old patient, and on the spectroscopy, you can see that there is elevation of choline and also a small lipid lactate peak seen. So based on the location of the tumor and the age of the patient, as well as the given MR morphology, the diagnosis is atypical central neurocytoma. So what are the key features? Intraventricular mass attached to the septum pellucidum. As you saw, it was a midline mass. It has a bubbly or a soap bubble cystic architecture. It may show areas of calcifications and heterogeneous areas of contrast enhancement. Next on your screen is the fourth quiz case, where you see a 10-month-old girl who presented with episodes of vomiting and MRI images showing this, again, T2 hypointense predominant T2 hypointense lesion in the posterior fossa with perilesional edema, mass effect and cystic component. Also subtle restricted diffusion and enhancement in the solid component of the lesion based on the location, morphology and the age group. The diagnosis in this case is medulloblastoma. So midline Vermian posterior fossa mass, which is hypercellular. So this is a lesion which will show you restricted diffusion because of its cellularity. So the learning point is anything which will be cellular, like lymphoma, like medulloblastoma, like round cell tumors, they will exhibit restricted diffusion because of the hypercellularity, relative T2 hypointensity and frequently associated leptomeningeal dissemination. So whenever you have a midline tumor like a medulloblastoma, you should always screen the entire craniospinal axis. You should perform post-contrast spine screening as well, just to make sure that there are no drop metastasis. Next on your screen is the fifth quiz case, where what you are seeing is another large heterogeneously T2 hypointense lesion, and on CT scan screening you could see that the entire bone has been eroded. So the features appear to as if it is a very aggressive mass lesion, lot of edema, associated calvarial destruction, mass effect is also there. But this patient additionally had no fever, and the patient is also immunocompetent when the history was taken in details. On SWI images, some areas of blooming were seen within. We could not make the diagnosis as such just based on the imaging, and we thought it is atypical meningioma or some aggressive lesion of the calvarium. But on the biopsy and histopath and microbiology, it was aspergilloma. So it was a aggressive form of aspergilloma which had destroyed the bone and which had a lot of mass effect associated with it. So the key points retrospectively are marked T2 hypointensity due to paramagnetic elements, which is what we look for if we are thinking about fungal involvement in the brain. If you remember the COVID days where we had a lot of fungal infections which were diagnosed as mucormycosis cases, that is what we were seeing. A lot of hypointensity on blooming areas on SWI and on T2 weighted images. Peripheral or heterogeneous enhancement and associated with sinus disease, sometimes it can cause calvarial or bone destruction. Another case where the patient had seizure episode, and what was very striking was this picture on ASL. ASL is arterial spin labeling, which is non-contrast perfusion, where you do not give contrast and still you can perform perfusion imaging. And more of such advanced sequences and the physics behind these sequences we will learn during the course, which I was talking about. So here what we see interestingly is that half of the half of the cerebral hemisphere is hypoperfused, that is on the right, and the left cerebellum hemisphere is hypoperfused. So this is a feature, a phenomena called as crossed cerebellar diaschisis. So which is contralateral cerebellar hypoperfusion on ASL occurs secondary to a supratentorial lesion. It is after effect and not the cause of any thing like seizure. It's just like a post-ictal change. Reduced metabolism without structural lesion, functional disconnection phenomena. So it's just a marker that there was an event in the supratentorial compartment and then the patient presented with seizure because of that. Next case, very simple one. What you are seeing is intramedullary lesion, which is showing peripheral enhancement, lot of perilesional edema. Now, the speciality about the spinal cord lesions is that because the compartment as such is very small as compared to the brain parenchyma, even a smaller lesion can present with disproportionate amount of perilesional edema. So here we are seeing these lesions, and as we go ahead, whenever you're seeing such kind of spinal cord lesion, it will be a good practice that you screen the brain as well for additional findings. So this patient had brain lesions with similar morphology, T2 dark, peripherally enhancing. And even in the lung parenchyma, there were some lesions which were better picked up on HRCT chest. So these are tuberculomas, which can be there inside the spinal cord also. So central caseatic T2 hypointensity, that is the key point whenever you want to identify something as a tuberculoma in the brain or in the spinal cord. It has to be T2 dark, ring enhancing, target sign appearance and associated edema in the spinal cord. Next is a case on your screen, which is a fetal MR. So this is a fetus which has been scanned using MR, and what you are seeing is a large flow void. So abnormal flow void, which is seen here in this fetus. So this is vein of Galen malformation in a fetus. Okay, so midline vascular flow void, dilated median parencephalic vein, high flow vascular channel. That MR will not tell you, but you can do a ultrasound associated Doppler with it as a screening, and associated hydrocephalus in neonates. So this is how you can see malformations in fetal MR. Next case, you are seeing some set of images which are showing you midline abnormality. It appears as if the cerebral hemispheres have got fused together. So this is scintillencephaly. So this is a case where you have partial fusion of posterior frontal and the parietal lobes, absent interhemispheric fissure in mid portion, separated frontal poles and occipital lobes, and associated corpus callosal abnormality. So that is, here you are seeing scintillencephaly. And the last quiz case, easy one, where you are seeing typical features of tuberous sclerosis. Patient also had the skin lesions, and here in the brain you can see these tubers. So cortical tumors, subependymal nodules along the ventricles, subependymal giant cell astrocytoma, which may be seen in association with tuberous sclerosis, and that's why these patients undergo routine repeated follow-ups with MRI and radial migration bands, which you can see in the white matter. So that is how you make the diagnosis of tuberous sclerosis. So thank you for participating in the quizzes, as we got a lot of responses, and winners also will be announced soon on the groups. Again, I would like to remind you that the registration are on. Please do register for the 25th MRI teaching course. It's next month. Venue is in Juhu area, Mumbai. All the details, the exact venue, everything is on the website of Indian Radiologist. As you can see on the screen, www.indianradiologist.com.